Okay. I am introducing Elizabeth Gilliams today. Dr. Gilliams has gained clinical expertise in treatment of HIV and STIs during her residency at Emory University in Atlanta, Georgia, and infectious disease fellowship at University of Washington in Seattle, Washington. She served as an HIV primary care provider and STI clinician during her training, and is the current medical director for STD services at the sexual health clinics at the Baltimore City Health Department since 2018.
Let me get used to these slides. It's been so exciting to come back and do in-person talks because then I can actually see how are you guys responding. So it's kind of like nice to not be talking into a void. So excited. I have no disclosures today, but just want to thanks to my colleagues at the PTC who helped develop some of these slides. What we're going to talk about today is recognize the importance of bacterial STIs, gonorrhea, chlamydia, and then in the same breath, talk a little bit about non-gonococcal urethritis, Microplasma genitalium, which is one of those new STIs that people are gaining recognition and the importance and recognition of. And then we're going to talk a little bit about management of those conditions. So we're going to talk about a little bit of a brief background. As you all know and are all here, you all know that STIs are rising across the country. The most recent set of data from 2019, and I know there's been a lot of delay due to COVID, we're expecting new sets of data coming out in I think the next couple of weeks, which is going to be very interesting to see and interesting to interpret because we know that testing has been a lot less during COVID. But with everything that we believe is going to be going on, that these cases will continue to rise, especially gonorrhea, chlamydia, syphilis, and congenital syphilis. I also like to start this talk too. This is one of my favorite slides from one of my colleagues, Dr. Ghanem, who really just lays out the probability of asymptomatic STIs among men and women across all different types of anatomic sites. You can see the majority of them are asymptomatic. And so this is really important to consider, especially as our colleagues were just talking about, the screening and the extragenital testing. And that's why, because all of these conditions can be asymptomatic, we want to be able to detect that and treat it and prevent onward transmission. So we're going to step next into gonorrhea. And I just pulled a few slides here from the CDC surveillance report. Most recently, as we can see for gonorrhea, over the past several years, cases have been rising. When looking at the breakdown between men and women, we see that the burden of disease is higher among men. And then looking at breakdown between race, we do see that people who identify as Black, there have been also sustained disparities in that group and higher rates of gonorrhea. And then looking at the bottom right, we see that there is also a marked difference between people who identify as men who have sex with men compared to women and men who have sex with women. And so these are priority populations to keep in mind as you're testing and screening. So folks may be familiar with sort of the clinical aspects of gonorrhea. It's the second most commonly reported communicable disease in the US. And you all may be familiar with sort of the male manifestations of urethritis. We see a picture here of penile discharge that can be sort of the typical purulent discharge, yellowish, but can be completely asymptomatic. In women, we're concerned about, can be asymptomatic, but we're concerned about ascending infection, pelvic inflammatory disease, which can lead to infertility, pregnancy issue outcomes, chronic pelvic pain, ectopic pregnancies. So this is really what's important to prevent and why we're screening for gonorrhea. Other clinical manifestations you may be aware of are that we just talked about are urethritis and cervicitis. There's also manifestations of conjunctivitis, and that can be seen in infants or to women with gonorrhea, but can also be acquired as an adult. And there are rare cases of that. Rectal infections and pharyngeal infections, again, many of them, the majority, close to almost all, are asymptomatic. So again, highlighting the importance of screening. And then in some cases, you may be familiar or heard of disseminated gonococcal infection. This is a condition where people have just disseminated spread of the gonorrhea infection beyond just an anatomic site throughout their bloodstream. It can be a life-threatening condition. So I'm going to take a few moments. We'll talk about diagnosis of gonorrhea. And first part of that, the first picture is, clinical assessment. Does the patient have symptoms? The second kind of consideration is, could we do a gram stain? This is a strategy that can be used most primarily in men. It's not sensitive in asymptomatic men. It's not sensitive or specific in women, so it's not used on vaginal discharge or on other body sites like pharyngeal or rectal sites. There can be just other bacteria that make this less feasible to really identify gonorrhea. But what we're seeing in the picture at the top right, that's a slide of urethral discharge. They're white blood cells, and you can see the sort of like lobular, sort of red stained nuclei, the little tiny dots around it. Those are actually the gonorrhea bacteria that can be seen. And so if that's diagnosed on a gram stain in a lab, like in a clinic, if you have that available to you, you can say, yes, I'm treating for gonorrhea today. Another way to diagnose gonorrhea is culture. And really, I know most people are not using culture, but it has an important role, especially when you're concerned about resistance. If you want to find out what antibiotics could potentially work for your patient if they have a resistant infection. For culture, the acceptable urogenital specimens are urethral swab and endocervical swabs. But please, if you have a question about culture, what should I be doing? Please reach out to the PTC Clinical Consult Network. We'd be happy to help you out with working that through for you. And then, of course, the NAT testing, nucleic acid amplification testing. That's probably what many of you are used to doing for detection of gonorrhea at all the anatomical sites, vaginal, cervical, throat, rectal, urine. For men, the most sensitive specimen is your first catch urine. And then other acceptable specimens can be a urethral swab, though many men prefer the urine, as we can probably all attest and recognize. And for women, a vaginal swab, even self-collect, can be very acceptable as well. And that's preferred over a urine test. So please, if you have the capacity to do a vaginal self-collect, if you don't have necessarily capacity to do a pelvic exam, you can do a vaginal collect, and that is more sensitive. Remember that self-collect vaginal, rectal, and oral swabs are accurate, but you want to check with your lab that they have been validated for use. So please kind of work with your lab to figure out what's allowed and what's not allowed. And if they want to do a validation, work with them on that, because that can help free up the capacity of you having to stick a swab on someone and them being able to just do the swab themselves, which is much easier if you don't have that clinical capacity. Another important piece around gonorrhea, kind of moving from the clinical aspect, is really recognizing that resistance to cephalosporin antibiotics and macrolides, so cephalosporins being our ceftriaxone, arcifixine, and macrolides being azithromycin. This is rising over past years and is actually an important priority of the CDC to monitor. And so what we've seen and what we're looking at here are elevated minimum inhibitory concentrations. So that's sort of the break point of where we see, is this a potentially resistant organism? So we're seeing, even though it's small numbers on the graph on the right or on the left, that this is rising for azithromycin and prompted some concern. We see that ceftriaxone and cefixime do remain at low levels, but this is because of our prioritization of sort of in recent years of really using that as our preferred therapy. But azithromycin is concerning. Also looking at the graph on the right, though, we also see that prevalence of resistance is not equal across all populations. We see that among men who have sex with men, the prevalence of azithromycin resistance is higher than men who have sex with women only. So this is a population that, again, we are concerned about for where there could be development or observation of resistant infections. And so I really like this slide for just kind of perusing medical history and sort of looking at the timeline of development of resistance to gonorrhea. It really kind of passes through sort of like the microbial history of development. I won't go through each step of it, but it's all to say that basically gonorrhea has blown through every antibiotic we have thrown at it, essentially. It has, gained resistance against penicillin, has gained resistance against sulfadrugs, gained resistance against fluoroquinolones, like ciprofloxacin. And so this is an urgent threat that the CDC has recognized. and sort of drove these recent changes to guidelines in the past in 2020. And so therapy for urogenital and rectal gonorrhea for the 2020, I guess, preview guidelines and was reiterated in the 2021 guidelines is now ceftriaxone 500 milligrams IM as one dose for people who are under 300 pounds. They recognize that for people who are over 300 pounds or 150 kilos, the dose of 1 gram is recognized, and that is really to get to a 5 milligram per kilogram dosing of ceftriaxone. And so that's the recommended treatment for gonorrhea on its own. It's no longer the ceftriaxone and the Zithro, it's just an increased dose of ceftriaxone to 500 milligrams. However, in situations where you have urethritis, where you're not able to rule out chlamydia presence, they do recommend co-treating with doxycycline for a week, 100 milligrams twice a day. And so in those situations where you would be empirically treating, you are kind of giving the both treatment, but in that picture, it's the ceftriaxone plus doxycycline. There is one approved or recommended alternative regimen for gonorrhea of the cervix, urethra, and rectum. If someone perhaps has a cephalosporin allergy, cannot tolerate ceftriaxone, this is still the gentamicin 240 milligrams plus azithromycin. You'll notice it's a higher dose, 2 grams, or cefixime 800 milligrams. You'll remember back, old guidelines was cefixime 400 milligrams. So the gentamicin regimen, that's the same, but the cefixime dose has also been bumped up. So why did the CDC change these dual treatment regimen recommendations, and why did we increase the dose? There was a bunch of research that led to these decision-making points, but first point being that antimicrobial stewardship is a concern, and as I talked about earlier, gonorrhea is on the list of urgent antimicrobial threats for loss of being able to treat this easily in an outpatient setting. So that's why the first reason why it was changed. Secondarily, we saw that there was increasing macrolide or azithromycin resistance over past years we were looking at there. And then lastly, in a mouse model, looking at sort of dosing of ceftriaxone at the 250 milligram dose, they saw that this only reached about an equivalent of like 3 mg per cubic body weight, which was not considered enough to truly eradicate all anatomic sites, rectal, pharyngeal infections. And so that's the reasoning around increasing that dose to 500 milligrams, sort of correlated to a human body weight regimen. What about pharyngeal gonorrhea? I mentioned we were talking about uncomplicated urogenital, but what about pharyngeal gonorrhea? So the dosing regimen that's recommended is the same. It's ceftriaxone 500 milligrams, and then sort of that bumped up dose for people over 300 pounds. But I'm highlighting here, there is no reliable alternative treatment for pharyngeal gonorrhea. That's part of what you're treating. So if someone says they have a cephalosporin allergy, you want to really dig in there and figure out what the heck is going on. Why can I potentially not treat this person? Because you could potentially get into a situation where this may not be covered by your choice of an alternative regimen. So those alternative regimens are not considered reliable. And so for pharyngeal gonorrhea, these new sets of guidelines, a test of cure is recommended at 7 to 14 days after treatment of gonorrhea, regardless of your initial treatment regimen. So all pharyngeal gonorrhea. And that's why it's also important to know whether pharyngeal gonorrhea is present, and to add that into your testing if that site has been exposed. You can use a culture or a nucleic acid amplification test. But if you do use a NAT, you're going to want to build in a culture, because if it's positive, you're going to want to know, okay, well, what antibiotics are working? Is it that this person was reinfected and maybe ceftriaxone is no problem? And maybe, this is not an issue. But if there is an issue with the ceftriaxone, you're going to want to, number one, report that to the health department. And number two, work with someone who has some expertise around what kind of other regimen will I offer to this person. For their partners, you're going to want to consider also contacting them and working with the health department too about that. And then, of course, all folks with pharyngeal gonorrhea and any diagnosis of gonorrhea should be retested at 3 months, regardless if they believe their sex partners were treated. That's just a routine for all folks. So why does the CDC only recommend ceftriaxone as the only preferred regimen in pharyngeal gonorrhea and a test of cure for all infections? And so ceftriaxone, we know there can be variable concentrations in the pharynx, and we know that can be more difficult to eradicate gonorrhea infections in the pharynx. And so there's still some uncertainty about how well antibiotics perform in the pharyngeal environment. So again, that kind of built the data for why are we recommending a test of cure. Next, they looked at could cefixime be used as an alternate regimen in the pharynx. And they saw that even in various dosing of 400, 800 milligrams, that it effectively treated only a proportion of the population given that dose. So it's also not definitively a good regimen, the cefixime. And then lastly, looking at gentamicin as an alternate regimen for pharyngeal infection, we saw that that was also not effectively eradicating pharyngeal infections. So again, this is kind of us grasping at straws and being concerned about treating gonorrhea in the future. It's scary, right? So what if someone has an allergy to a penicillin? You're like, I really want to treat this pharyngeal gonorrhea, but they say, oh, I had a baby, I was a baby, I had an allergy, I had a rash, not sure what happened there. Please stop. Don't avoid ceftriaxone just because of that. Again, you want to dig in there, stay calm, ask some questions. You're going to want to ask, what was that reaction like? When was it? How long ago was it? Have you taken other similar antibiotics? And I'd like to go down the list of, have you taken Augmentin? Have you taken amoxicillin? Have you taken Keflex? Those are all sort of similar antibiotics. And if you can say, oh, that was no problem, then you can feel pretty confident they can take ceftriaxone. You want to ask, is this an immune-mediated reaction? Is it IgE mediated? Could they go into anaphylaxis? And if they tell you, I carry an EpiPen, and because I had to take that, you know, maybe they don't carry an EpiPen, but because if they can tell you a pretty consistent story with anaphylaxis, then you're pretty sure that they can't take ceftriaxone. But up to 80% of patients with IgE-mediated penicillin allergy lose that allergy after 10 years. So this is the situation where you may want to work with an allergist if you have someone available to you. And then also if they have a delayed onset or a T-cell mediated type reaction, being either that's like SJS, Stevens-Johnson syndrome, DRESS, drug fevers, you still want to ask questions, but this is something that you may want to sort out with an allergist. But all hope is not lost because in several studies looking at cross-reactivity between penicillins and ceftriaxone specifically, there was basically no cross-reactivity for people who had penicillin T-cell mediated allergy to ceftriaxone. So if you can say, oh, I can give these people, there's very little chance for that cross-reactivity. And then also on the paper on the right, we see that people who had IgE-mediated hypersensitivity to penicillins, if you can rule out that with skin testing, many people did not have actual cephalosporin allergy. So this is something that it can be done. That cross-reactivity is not always a given. So just to move on kind of away from that allergy discussion, sort of a little bit of my soapbox here, but to move next into pelvic inflammatory disease. What if you're trying to treat that in an outpatient setting and someone has a ceftriaxone concern and allergy? Many cases of PID can be treated in the outpatient setting. And I would say that the only recommended outpatient regimen by the CDC does contain ceftriaxone. So please try to, drill down that ceftriaxone allergy if you're trying to treat PID. And just last few words about gonorrhea is that there are several drugs that are in development for treatment. However, many are still in phase 2, phase 3 stages. Not all of them have reliable efficacy as ceftriaxone does. So there are things in the works, but again, still not a great situation moving forward. So some take-home points for you to just remind, again, the dosing of gonorrhea, now up at 500 milligrams, no longer co-treating with azithromycin for all cases. But if you haven't ruled out chlamydia, do treat with doxycycline for a week, and we'll get into why we switched to doxycycline. And then for pharyngeal gonorrhea, please collect a test cure at 7 to 14 days. I'd love to hear and talk about how you guys are doing that, because we're trying to implement that in our sexual health clinics, and it has been hard. It has been hard. And then please try to get a thorough history of a penicillin allergy. Many people can be treated with ceftriaxone. And then, of course, test people all 3 months, and then treat all sex partners in the past 60 days as a contact gonorrhea. Yes.
There's a question in the chat. And the question is, I thought the NAP test could be positive 3 weeks after treatment, so why test at 7 to 14 days?
That is a great question. The question is, why do a test of cure for pharyngeal gonorrhea at 7 to 14 days with a NAT when it can be positive at up to 3 weeks? That is so true. So that was one of the biggest criticisms, I would say, of the new CDC guidelines, because you can have persistently positive NATs, which is basically just genetic debris. And as we're all familiar with COVID, if you were to be tested for, like early on in the days, we were like, let's do a NAT to clear you of your isolation, and it was still positive, but you don't have any like active virus. There is just dead genetic debris there. So that is a concern. I will say for many of our clients, at least empirically what we've seen of people who are doing test of cures in our clinic within the 14 days, many of their NATs are negative, which is reassuring. It can be positive out to 3 weeks. And if you do get into that situation, I kind of aim to do my test of cure around 14 days. So I think 7 days is pretty early, my personal opinion. So if you are doing a test of cure, I kind of aim for the 2 week mark. And if that's positive, then I would proceed to getting a culture at that point and trying to assess that out.
And there's one other question. What if the patient refuses an injection-based therapy for pharyngeal gonorrhea? Would you recommend fixing and repeat culture?
So I think we're in the business of trying to reach patients where they are. If you absolutely cannot get an injection into someone, I think you have a very thorough conversation with them as much as you can. But if you are up against a wall, I would say provide a treatment that you can give. I would consider treating with perhaps ceftriaxone or cefixime 800 milligrams, but I would absolutely get a test of cure. And of course, all pharyngeal cases or treatments are getting a test of cure. And then I would have a very low threshold to work with a specialist to figure out how to treat that. But I would absolutely exhaust all my opportunities to provide ceftriaxone. Yeah, thanks, Jeannie. Great. So we're going to take a deep breath, move on to chlamydia, and just to talk a little bit about different epidemiology trends with chlamydia. As you may be familiar, of course, we've been talking about cases are rising over the past several years. But this infection is a little bit flipped, where we're seeing that the cases are highly detected among women, and those are kind of trending upwards as well. There's a lot of discussion around, this is probably related a lot to recommendations around screening, and then there's no recommendations around screening, so you're not detecting it perhaps as much. But this is what we're seeing with surveillance, and that we're seeing that the populations where it's most cases are detected are between ages 20 to 24. Which is probably not a surprise to this group as well. And so I just want to take a step back and say chlamydia has several different serobars that are named with different letters. And so serobars A through B and C, these are actually the bacterial infections that cause trachoma, which is an eye infection, which is more of a relevant issue in sort of global health situations. Not really an issue we're going to talk about today. Serobars D through K, these are the typical serobars that you would see in the United States for genitourinary and ocular infections. And then sort of a special subset of serobars, L1 through L3, are responsible for a clinical manifestation of chlamydia called LGV, or lymphogranuloma venereum, which you may have come across as sort of a concern when considering chlamydia infection and proctitis. So we'll walk through a little bit of that. But sort of your typical chlamydia, the serobars D through K, again, this is one of the most commonly reported STI in the US, but again, not all STIs are reportable. So think that perhaps, HPV is very prevalent not reportable. But the majority of these infections in general, sites in both men and women are asymptomatic. And that 10 to 15% of untreated chlamydia infections result in PID. So that is a concern. The clinical picture that you may be familiar with typically for urethritis is sort of a more clear, just penile discharge, as we're seeing in the picture at the top right. And again, cervicitis with vaginal discharge. But other clinical pictures could be epididymitis or prostatitis in men, or pelvic inflammatory disease, as we spoke about. And then proctitis or proctocolitis, which is even an involvement of the colon. This can often be asymptomatic, but when it is present and there are proctitis symptoms, you may recognize sort of an urgency to void, bleeding with stools, abdominal pain. So those are the things that I would keep my mind on if someone had a rectal infection, I would ask about. And then also, of course, conjunctivitis is a possibility in neonates as well as in adults or adolescents. And then reactive arthritis is another manifestation. The picture on the bottom right, that's a picture of reactive arthritis, which is actually an autoimmune reaction to the chlamydia infection, which has sort of cross-reactivity in the joints. It can cause inflammation of the joints, even while you're treating through the treatment of chlamydia. So that's one thing to keep in mind, but should resolve with appropriate treatment. So kind of jumping now to LGB or lymphogranuloma venereum. Let's talk a little bit about what it is. The classical manifestation of it is a short-lived painless genital ulcer that appears accompanied by an inguinal lymphadenopathy or swelling of inguinal nodes. There were outbreaks that were observed in the US and Western Europe, most recently though, among MSM with proctitis. And this is actually the manifestation that we've seen most commonly, at least we have observed in our clinic. We had access to a research test at Johns Hopkins. So we actually were able to diagnose some cases of LGB in our clinic. So it is present in Maryland, it's present in the US, and it is circulated, but probably not appreciated as much as it actually is there. And so what you may see with this manifestation is rectal pain, tenesmus, trying to avoid but having difficulty, pain with that, rectal bleeding or discharge, purulent discharge, pus. And it could be mistaken for inflammatory bowel disease, such as Crohn's disease, ulcerative colitis, potentially even C. diff diarrhea, but can also be histologically compared to that, as well as early syphilitic proctitis, which is, again, a more rare situation. The diagnosis, as we walked through for gonorrhea, for chlamydia, very similar. You're going to first assess for symptoms. On gram stain for chlamydia, what you won't see is an organism there, because it is an intracellular organism. It cannot be stained. But what you could see is presence of a lot of white blood cells in the urethral discharge. And so essentially, if you have access to gram stain, put some urethral discharge on a stain, you'll just see a ton of white blood cells. There's no gonorrhea. That's essentially non-gonococcal urethritis. And by default, is sort of, we move to treating to chlamydia for that as the most common cause of it. Nucleic acid amplification tests are really your mainstay, as many people are familiar here today. And of course, the same specimens that were preferred for gonorrhea are preferred for chlamydia as well. And then as far as rectal infections, there's no widely available FDA cleared test to test for LGB. If you were to try, if you're thinking, do I have a patient with LGB? What you're going to do is get a regular, chlamydia NAT. If that's positive, plus a picture of, proctitis, rectal discharge, that's a situation where I'm like, maybe I need to consider treating this person as if they have LGB. You could potentially, if you have access to a research lab, there are a few across the country, work with them to send that swab for serotyping for that L1 through L3, but it's not widely available. So most diagnoses and management of LGB is clinical alongside having a positive chlamydia rectal test, NAT test. So some take-home points around the treatments for chlamydia. It's now recommended by the CDC to treat chlamydia with doxycycline twice a day, 100 milligrams for a week. That's the preferred option. Azithromycin, no longer the preferred regimen. And the reasons being, there were two very large studies done alongside many observational studies showing that azithromycin was 3% less effective when treating urogenital infections compared to doxycycline, and that azithromycin was 20% less effective when treating rectal chlamydia infections compared to doxycycline. And so those two figures, around 20% difference, were observed in both of these large studies. And so that really drove the change in recommendations. And so alternatives that exist, and there still is azithromycin if needed, if someone has a huge issue with doxycycline, or if someone is pregnant, that is the preferred regimen is azithromycin, 1 gram. Levofloxacin is also present, but usually is not what I reach to for treating for chlamydia, because usually most folks can tolerate either doxy or azithromycin. Your options for pregnancy, again, azithromycin or amoxicillin, 3 times a day for 7 days. And then I want to underline specifically for chlamydia in pregnant people, that it's recommended to perform a test of cure at 4 weeks after completion of treatment. This is one of the other few places where a test of cure is recommended, aside from pharyngeal gonorrhea. And then, of course, always remembering to rescreen all persons 3 months after treatment for concern for reinfection. And so, as we just spoke about chlamydia during pregnancy, there are screening recommendations recommended. And again, for all women under 25, that's a given, but especially in women who are higher risk, it's recommended to screen at diagnosis of pregnancy, at the first prenatal visit, and then at the 3rd trimester again as well, to avoid pregnancy complications. And so chlamydia proctitis, we spoke a little bit about this, the LGB potential proctitis. So again, no commercial tests available for that. And so the duration of chlamydia proctitis treatment really depends on what is the clinical picture in front of you. And so if you're seeing someone who has very mild symptoms of proctitis, they're not having a lot of pain, you could probably cover that with 1 week of doxycycline, and that's sufficient. So just a routine chlamydia management with a week. But if they've got moderate or severe symptoms, they are having some bleeding, they're having a lot of abdominal pain, rectal pain, you're going to want to treat with doxycycline for 3 weeks. And so in my practice, if someone has proctitis clinically, often you're going to treat them empirically in front of you and say, okay, I'm covering for gonorrhea and chlamydia while I'm waiting for results to come back from the lab. And then if the chlamydia rectal test NAT is positive, and they're still having sort of severe symptoms, I'll say, okay, I'm going to extend your prescription from 7 days now to a full 3 weeks. And that's kind of how I think about it in my practice. So screening recommendations. I actually really like how the CDC put this out, at least on their website for recommendations. I am not going to go through each of the different areas, but what I'll say is that the CDC has put out on their website with the the whole treatment, STI treatment guidelines. You can you can go through the website by either condition, who should be screened, or by population. So if you want to say for women, what should I be screening for? Here's the list. If I want to look at, let's say, chlamydia, who should be screened for that? You can look at that list and kind of toggle between the two. But the big areas for screening for chlamydia and gonorrhea, of course, stay the same. Women under 24 and under, still recommended to screen annually per CDC guidelines. And then higher risk women annually are recommended to screen for chlamydia and gonorrhea. And that definition is if someone has had multiple sex partners, they've had new sex partners, inconsistent condom use. And then, of course, for all pregnant women, irrespective of age at first prenatal visit. That's the kind of area that I would 100% focus on. For men, the CDC recommends all sexually active men who have sex with men being screened annually at all sites of exposure. And then targeted screening of other folks at other sites and other sort of settings, depending on prevalence. And so Looking at different populations, we just talked about sexually active MSM being screened annually for gonorrhea and chlamydia, all sites. MSM at increased risk should be screened every 3 to 6 months, and that may align if someone is on PrEP to screen every 3 months for that as well. I like to call out specifically transgender and gender diverse people. There's no sort of hard and fast screening recommendations for gonorrhea around that group. However, CDC recommends based on the anatomy, their sites of exposure, and their behaviors. And so I think you can have that discussion as sort of a shared decision-making process with your patient. And then as we said with PrEP, those folks should be screened every 3 to 6 months. Why screen for extragenital gonorrhea and chlamydia infections? I hope I made this case to you that many are unappreciated if they are not tested for, and they are often asymptomatic. And that these are an important infection of public health significance because there can be still transmission, of course, when someone is asymptomatic. And then for what of extragenital gonorrhea and chlamydia screenings for women or men who have sex with women only? There are no official CDC recommendations for this group. However, I think this is still an important conversation to have with your patient. But in my practice, I recommend screening men who have sex with women and women based on their exposures, their network. I think in many of us, if we work in a sort of sexual health-based setting, then I think that is necessarily a group that's higher risk than other folks. So I don't lose any sleep over adding that into screening for my patients. And then this is all just to say that the duration of extragenital gonorrhea and chlamydia infections among MSM can be an astounding number of days because it goes unscreened, because it is so asymptomatic. And again, underlines the need for ongoing screening there. I want to take a step back and talk about a little bit about the clinical syndrome of, again, non-gonococcal urethritis, which is a big bucket basket term of sort of urethritis that's everything that's not gonorrhea. And what could that be then? So more common etiologies, again, chlamydia. So often if you were in a setting where you had a gram state, your patient had urethral discharge, that discharge didn't have gonorrhea in it, you're going to target, okay, I'm going to go ahead and treat for chlamydia off the bat here today with some doxycycline. However, there are a bunch of other reasons that could be causing this urethritis, including Microplasma genitalium, including trichomonas, especially in men who have sex with women. In MSM, it's much less likely because Trichomonas vaginalis likes to live in the environment of vaginal tissue. So exclusively MSM patients, I would not consider that likely. And then herpes as well, but other things can cause urethritis, being enteric bacteria like E. coli, if someone participates in sort of anal intercourse. Can also be viral infections like adenovirus that can be transmitted from oral sex. And so it's a number of things. What I'll say is that up to 50% of cases may not have an identified cause, even among these particular pathogens, which is frustrating for providers. So I want to move next into Microplasma genitalium and kind of underline sort of the uncertainty and that is felt among providers. But know that MGen can cause symptomatic and asymptomatic urethritis in a number of cases. It can be a large number, up to 40% of persistent urethritis, and so that's important to recognize. In women, Mycoplasma genitalium can be associated with cervicitis, pelvic inflammatory disease, a lot of other important complications. But there's really not a lot of hard data to show that treatment and screening and treatment of MGen prevents these outcomes. It's really sort of a loose association that we're trying to work out right now. Rectal and pharyngeal infections have been documented of MGen, but their significance is uncertain because it's not clear whether they're usually not symptomatic. We don't know how much they contribute to actual transmission to the urogenital site. And NAT testing for MGen is FDA approved for urogenital sites. But most of these do not have macrolide resistance testing available to them. And this is a big concern for Microplasma genitalium, is that they are often resistant to azithromycin. And so you're going to have to choose your antibiotic regimen based on not having a whole lot of information necessarily. So the CDC did have comments, though, on how to treat MGen, which is a little bit more than what they had in 2015, which is reassuring and helpful. But really the role for testing for MGen is specifically in men with persistent urethritis. I want to say again, men with persistent urethritis, not the first thing I'm going to test for when someone has urethritis. I'm going to aim for gonorrhea, chlamydia, but not MGen as my first line of testing. You can consider testing for women with PID, but there's, again, as I just said, not a lot of evidence to support that link of does treatment help prevent these outcomes, poor outcomes from PID. I would not screen for MGen in men or women. Please do not screen for MGen at urogenital or extragenital sites. There's really not seen to be much benefit from doing this practice. And so the CDC now recommends a two-stage approach to treatment of Mycoplasma genitalium. And they stratify it by whether you have access to resistance testing for azithromycin or macrolide sensitivity. But many places do not have that access. And so that often leads you to a situation where you kind of have to assume that the organism is resistant. And so if you do have that resistance testing available, they do recommend doxycycline 100 milligrams twice a day for a week, followed by azithromycin 1 gram once, and then a 500 milligram dose daily for 3 days. And so that's a, let's see, 7, 8, 9, 10, 11 day course in sequence. However, if you do not have macrolide testing, or if it is resistant, you're going to aim for sort of a scaled up, broader antibiotic regimen, which first starts with doxycycline again for a week, twice a day, and then followed right after that with moxifloxacin once a day for 7 days. So a total of 14 days of treatment. So you don't want to put them together, and sort of the basis around this treatment regimen is the thought that the doxycycline reduces the antimicrobial burden, knowing that it's not going to clear out all of your MGen, but once that moxifloxacin gets in there, it's going to clear out most of the infection. So it's really important to instruct your patient, take the doxycycline for a week by itself first, then the moxifloxacin for a week. And then partners, I would consider testing them. And if you can't, I would consider treating them based on the regimen that you gave your initial patient. And so just another thing to say, we just talked about how PID and screening for Mycoplasma genitalium, there's not a lot of great evidence for that, but personal advice would be, I would not off the bat treat all women with PID or test all women with PID for MGen. But if they are failing PID therapy, then that's a consideration of when I would test for Mycoplasma genitalium and then treat for 14 days with moxifloxacin, a longer course because of PID. And so urethritis in men, I made a couple of different sort of algorithms. Excuse the very basic nature of this, but I like to kind of lay it out visually, kind of lay out what are my decision points here in treatment. So if you've got a patient in front of you, they've got urethritis clinical signs. Let's say you don't have point of care testing like a gram stain or another point of care gonorrhea, chlamydia test. You're going to go ahead and treat empirically for gonorrhea and chlamydia until you get your results back. And then, however, if you do have point of care testing that can help mirror your antibiotic therapy, if your gram stain or point of care gonorrhea test is positive, go ahead and treat for that. And if chlamydia is negative, only treat for gonorrhea. If you have a chlamydia test that's positive, or you have white blood cells on your gram stain, you're going to go ahead and treat for NGU, which is essentially chlamydia therapy. Persistent urethritis. This is the situation where you've treated and they have had nothing, perhaps treated for NGU with doxycycline for a week. Their symptoms are still there, and their gonorrhea and chlamydia tests were negative. What should we do? You want to evaluate them and confirm that they have persistent urethritis. And I put up a few criteria here by either, gram stain or stain availability or microscope urine assessment. But for this graph should show on the second level, on the left side, among men, both sex and women, you're going to want to test for both trichomonas and Microplasma genitalium as your two next sort of options. And I would wait. I would not treat anything that day. I would say, let's get your results, because I don't want to overtreat you with antibiotics. On the right side of the graph, it should actually say test for Microplasma genitalium for MSM only. I'm not going to test for trichomonas and MSM because it's not going to be there. And then I would wait and treat based on the results after that. If everything is negative, then I think that's worthwhile to work with that patient. Perhaps they need to work with your urologist. Do we need to see if they have ongoing actual urethritis? Maybe they actually don't, and they have irritation. And sometimes they are in that category of 50% of urethritis has no cause that we can identify. EBT, I just want to put a little reminder out there for folks. It's an effective way to treat partners. It is permissible in Maryland. And so it is a provision of an appropriate antibiotic or prescription to a patient for their partners to take. And should include all these elements of the medication, condoms, some information about the infection, and also potential allergies that the patient can read through and decide whether they are concerned about taking this medication. Partners within the past 60 days are eligible and is permissible for gonorrhea, chlamydia, and trichomonas. It is not considered ideal for MSM, and I would consider a decision-making process that's harm reduction focused, because we know that for MSM, there are many services that they could access and are important to access in a healthcare setting. And so including HIV testing, including a discussion about PrEP. But if this partner is like absolutely never going to come in, we want to provide some sort of treatment. But we're kind of also worried potentially for gonorrhea, could we be treating them with a vaccine that may not be effective? Could it be resistant? Could the gonorrhea be resistant? So that's kind of an area where I think it's a very thorough discussion that's needed. But if you are going towards the route of EPT, for gonorrhea, what I would recommend is vaccine 800 milligrams once. And if chlamydia infection has not been excluded in your index patient, then I would add in the doxycycline. However, if that patient their partner could be pregnant, I would recommend azithromycin instead as that management for chlamydia, for the gonorrhea treatment and for the chlamydia. Last thing to say, there's a lot of great information out there about self-collection of specimens and home collection that has really been sort of trailblazed and bolstered during COVID, especially as we're trying to social distance a bit more. So this is, I think, a large part of the landscape that will be coming forward. Perhaps you have even seen patients who have come in with results from iWantTheKit, one of Maryland's home testing programs, or from another online testing program. And then lastly, again, the Stb Clinical Consult Network is a free network where you can submit questions about management of STIs, all STIs. And so Jeannie at the PTC can definitely connect you, or you can even just go directly to that Stb Clinical Consult Network. And so you'll get experts in the field who are able to answer your questions. That's everything for me. Thank you for being a wonderful audience. I'm happy to take any questions that may have come up in person or in the chat.
Do you have any questions here? Yes. Could you go back 2 slides? Because I do want to share. Yes. That those pictures there are posters, and if you want to get those, they have them in Spanish and English. The PTC in Seattle has created these, so I just email me. I can connect you with the right person, and she will send them to you. So by all means, let me know, and I will go ahead and share that with you. That's not a problem.
Yeah, they're wonderful. We've sort of pasted them across our restrooms for folks who are coming in for self-testing, for what we call express testing. We're just doing asymptomatic testing. It's just a perfect combination of working with like a medical assistant. They get in and out, they do their swabbing, and it runs pretty smoothly.
We have several questions.
Okay.
The first one, can you speak to the sensitivity of TRIC testing in men? We actually charge for it.
Okay. Sensitivity of trick testing for men. I don't have it at the tip of my tongue. I'm guessing you're probably aiming for sensitivity of NAT testing. I would say it depends on the specimen. Is it a first void? Is it a urethral discharge? If it's one of those sort of higher yield specimens, then I think I would say I would have to estimate, I don't have it to my tongue, but I would estimate it's over 80% sensitive. I think the question is there recommendations around screening for trichomonas at the moment? And then no, but I think I would consider, of course, as a contact, I would treat a contact to a case that is known. I would test for someone who has a persistent urethritis, of course, for trichomonas if it's someone who has female partners. And those are kind of the main two situations I would think through, but it's out there, but it's not like my first line screening test that I would go for. And again, trichomonas is not a reportable condition either. So it's not on that top list that we're tracking as frequently either at the CDC or at the state level.
You did say, please repeat my question because I can't hear.
I'm sorry.
So could you talk about TRIC-NAT sensitivity of vaginal swab versus urine sample?
Okay, could we talk about sensitivity of trichomonas NAT testing for
Vaginal swab versus urine.
versus urine? Okay, yes, great. I would actually, as in many of the sort of vaginal testing versus urine testing, the sensitivity for gonorrhea and chlamydia and trichomonas is going to be better at a vaginal self swab over a urine test in women. And so that difference may be on the order of about maybe 70, 80%. I'd have to look back specifically, but can't get back to Jeannie for urine. Whereas in vaginal swab or even a cervical swab, if you're doing a pelvic exam, could be in the order of around 90% or more. So I would definitely prefer a vaginal swab over urine.
Okay, the next question is, how long after taking doxy is too long before starting moxifloxacin? And will you have them take the doxy again?
A really good question. For Microplasma genitalium treatment, how long is the time period? Is too long if there's a lapse between that lead-in with doxycycline and then starting at the moxifloxacin. I don't think the CDC does not comment specifically about this in the guidelines, but what I would say is if it's more than like maybe a couple days, 2 days or so, I would be concerned and I would kind of have them do a lead-in as well, because really what you're trying to do is set the stage for effectiveness of the moxifloxacin to work. And again, I don't take tight treatment of Microplasma genitalium lightly. Moxifloxacin is a very broad spectrum antibiotic. Fluoroquinolones have issues related to tendon rupture, antimicrobial resistance, risk for C. diff diarrhea. And so this is all to say that I don't just rip off the seal. I'm like, oh, you've got persistent urethritis. I'm going to off the bat treat you for MGen. I want to have a test result in hand to treat this person if I can.
Okay, and then the last question that I have here, second last. For urethritis in men, would you send a urine culture?
For urethritis in men, would I send a urine culture? I think I would assess that person's symptoms. If their clinical picture is really urethritis, which is penile discharge, then that is primarily going to be, I'm going to be concerned primarily for gonorrhea, chlamydia, and all those other pathogens we just spoke about. If the person is having sort of urinary frequency and I don't see a penile discharge on exam, then I might be concerned for UTI, but I think it would I would aim my diagnostics toward what is the risk factor for this patient, what's going on with them. If this is a 50-year-old man who has not had any partners for 2 years and they're coming in with urinary urgency, that's kind of a different picture than someone who's maybe 25, has had 3 recent partners in the past 3 months. I would consider more of a prostate etiology or a UTI, perhaps in an older population, not to say, as our colleague said, age is not a condom. But a urine culture would not be part of my first diagnostics for urethritis or penile discharge.
Okay, and another question is, if a client cannot give a first warning urine, for whatever reason that may be, what is recommended on the urine sample and how long to not hold it before testing?
Got it. Good question. So if a patient cannot give a first warning urine, what's the best type of urine specimen to get? And so first void, I would say first warning urine preferred, but if you can get a urine sample where a patient has not urinated for at least the past 30 minutes is a preferred specimen.
That is all I have.
Lots of good questions. Thank you so much. Any other in-person questions here today? Well, thanks for having me. And I hope you enjoy the next talks that you have today.